You're all very welcome to this evening's edition of the Breaking the Pain Cycle webinar series. My name is Peter Boyd. I'm the Services Support Officer with Arthritis Ireland. I'm joined by my colleague, the Services Manager with Arthritis Ireland, Martina Blake, and I'll introduce you all to Elena Nikiphorou in just a couple of moments, who will be giving our talk this evening. So just as usual, a couple of housekeeping pieces of information. Those of you who have been with us throughout the series will know that we are the national charity for people living with arthritis and the go-to place for people with all things arthritis. We deliver support, training, education and information, including webinars such as this. And our free national helpline is open Monday to Friday, 10 a.m. to 4 p.m. for support and information. So any questions that you have that come up that we don't manage to get to, please do contact us and we'll do our very, very best to answer them for you throughout the week. And there's our helpline number at the bottom of the screen. So, as I've said, these are our series of Breaking the Pain Cycle webinars. They will be recorded and you can watch them back on our YouTube channel later on. They're scheduled to last around an hour, but we'll have time for questions and answers as well built in. And all you need to do is to put your question into the question box at the bottom of your screen. And I will do my best alongside Martina to put as many questions as we can to Elena after the talk. So we will do our very, very best to get through all of your questions. We will also have as I said, the webinar recorded and available on our YouTube channel at after the conclusion of our webinar. So there we are. That is our the three of us for this evening, but it gives me great pleasure to introduce Dr. Elena Nikiphorou, who's a consultant rheumatologist at the King's College Hospital and an adjunct senior lecturer at King's College in London. Clinical interest in and an academic interest in inflammatory arthritis, comorbidities, and the long-term outcomes of disease. But particularly relevant to this evening is a keen interest in the role of nutrition in rheumatic diseases. And Elena has delivered relevant talks at national and international level, as well as editing the first ever EULAR module on nutrition in RMDs. So lots and lots of experience. Elena has been involved with several EULAR task forces on the development of recommendations and has been a co-convener, first author on lots of different the recommendations on the implementation of self-management strategies in inflammatory arthritis. So vastly experienced, vastly knowledgeable. And if I haven't built you up too much, Elena, I will leave the floor to you to carry on with your talk for this evening. And as I said, for everyone to put their questions into the questions and answers box, and we will get through them as much as possible after the talk.
Thank you very much, Peter, and a very good evening to all of our attendees. I'm delighted to be in your company this evening. And it's also great to see the interest that this webinar has attracted. I think it shows the importance and the relevance of the topic to people living with rheumatic diseases, but not only. So we live in times whereby we have a wide variety of pharmacological therapies to manage rheumatic and musculoskeletal diseases. But we also have a greater understanding of the potential of non-pharmacological self-management strategies for managing disease. And diet is one such example. So these are my disclosures. And just before I begin, I would like to actually start with some acknowledgements, specifically of the three colleagues listed here, starting with Professor Elena Nikiphorou. I work closely with Elena, another Elena. We've often covered this topic together, and some of the information and tips that I will share come from her and her expertise as a dietitian. And also Professor Cutolo and Dr. Francesca Oliviero, both based in Italy, with a rheumatologist and a nutrition scientist respectively. And we've exchanged lots of thoughts and ideas on the topic over time. And again, I will be sharing some of these during the course of this talk. So, nutrition and inflammation, what's the link? We know that inflammation is central to many rheumatic and musculoskeletal diseases. But what is the link between nutrition and inflammation, and therefore nutrition and rheumatic diseases? You may have heard of the mosaic of autoimmunity. This is a concept that refers to the multifactorial origins and the diverse expression of autoimmune disease. And the concept acknowledges the interaction, the complex interaction between our genes, our immune system, our hormones, and external or environmental factors. And nutrition is an external environmental factor.
Brilliant. So I was just explaining this mosaic of autoimmunity, which is naturally relevant to rheumatic and musculoskeletal diseases. And I have mentioned inflammation earlier. I hope you could hear the note I made specifically on inflammation being right at the center of many rheumatic diseases, but not just the rheumatic diseases. Inflammation is central to the pathogenesis of many other coexisting conditions with the rheumatic diseases, what we refer to as comorbidities. So you will see that what I will tell you this evening is not just important and relevant for the rheumatic disease itself, but also for comorbidities. But how can healthy eating benefit people living with rheumatic diseases? In a broad sense, healthy eating can help us reduce the levels of inflammation in the body through the intake of more anti-inflammatory foods and less pro-inflammatory foods. It can help us to optimize our body weight and body mass index through balancing the intake of food versus the body's needs. And it can also help us to reduce the risk of comorbidities, such as high blood pressure, diabetes, or osteoporosis, to name a few. And let me share with you some of the scientific evidence that is out there without dwelling too much on the detail. But I've been selecting in the studies that I will show you for various reasons. And I believe that you can see my pointer here on this slide. So this is a study that looked at the association between the dietary inflammatory index, which is a measure of how inflammatory a food is, the food consumed is, and it's computed from food frequency questionnaires that the patients complete, and its association with disease activity and inflammation in patients with rheumatoid arthritis. It was what we call the case control study. So 100 patients with rheumatoid arthritis were matched to the same number of healthy controls based on age and gender. And to cut a long story short, the two big messages that came out from this study were that, first of all, patients with rheumatoid arthritis were generally consuming more inflammatory diets. So the DII was higher compared to healthy controls. And on moving from a less inflammatory to more inflammatory diets, so Q1 all the way to Q4, the different levels of the DII, the higher the levels of C-reactive protein in the blood, which is a measure of inflammation, higher the levels of TNF-alpha, which are central to the pathogenesis of rheumatoid arthritis and other rheumatic diseases, the worse the disease activity, and the higher the number of tender joints in these patients. So in other words, this study showed that there was an association between how inflammatory a diet is and pain levels and disease activity in patients with RA. This is another similar type of study, a case control study, whereby again, patients with RA, this time double the number of patients, were compared to the previous study, were matched to healthy controls based on age and gender. And this study, that it's called the Tomorrow study, it had a longitudinal component. So it had a follow-up period of 6 years. And the big message from this study, again, keeping it very top line for our attendees this evening, was that a change in the EDII from a more inflammatory to a lower inflammatory level, so less inflammation, was associated with a better chance of sustaining low disease activity in those 6 years in patients with rheumatoid arthritis. And this is another study that looked at, it's a systematic review of the literature, so it looked at many other studies that were published, and specific analysis was undertaken on the results of each of these studies. It looked specifically at the effect of anti-inflammatory diets, we'll talk about this a bit later on pain in patients with rheumatoid arthritis. So you will see that a lot of the studies that I will present in the literature of nutrition and rheumatic diseases come from patients with rheumatoid arthritis, one of the commonest types of inflammatory arthritis. And essentially, this study showed that the use of anti-inflammatory diets was associated with less pain in patients and lower levels of C-reactive protein, so an inflammation marker, although in the case of CRP, this was not significant. But what you will see in the studies included is that many of them are old. They are also subject to methodological limitations. It's one of the problems with the literature in nutrition. We'll talk about this a little bit later on. But what it does say is that it's very important to exert caution when interpreting the results of these studies. Nevertheless, I think there is an important message out there still to suggest that nutrition plays an important role in inflammation and therefore in rheumatic diseases. Now, this is another interesting question. Can the way we eat actually increase the risk of developing a rheumatic disease in the first place? Again, I will go back to the evidence and I will share with you this time the findings of a large study from the US led by Jeff Sparks in Boston. This was based on the Nurses' Health Studies 1 and 2. Huge number of women included in these studies, 170,000, so big numbers. And the study looked at again, the inflammatory dietary pattern and the risk this time of developing rheumatoid arthritis in women. And it did find an association. In women of up to 55 years of age, there seemed to be an association between the consumption of more inflammatory diets and a higher risk of developing rheumatoid arthritis. There's another study that this time looked at the dietary intake of what we call the long-chain omega-3 fatty acids. We will talk about fatty acids in a bit more detail very soon, and the risk of developing rheumatoid arthritis. Again, a very large cohort of patients included, 32,000 women from the Swedish mammography cohort, and the study showed that the higher the intake of these omega-3 fatty acids, the long-chain fats, the lower the risk of developing rheumatoid arthritis. So take-home message 2 I'd like to share with you is that there is also evidence to suggest that diet does play a role in the onset of rheumatic diseases too. But does the type of diet we choose actually matter as a whole? The modern diet that's practiced in many Western societies has been described by some as the worst enemy of chronic inflammatory conditions. It is characterized by high amounts of the wrong types of fats, high amounts of salt, sugar, refined carbohydrates, and processed foods, which makes this diet very inflammatory. Now, I've already talked about the omega fatty acids, and I want to spend a little bit of time on them because I think this is particularly relevant and important to understand. Oils are made up of fatty acids. It's part of the natural chemistry of the oil. Fatty acids are essentially chains of carbons for those with a biochemistry of biology or a biology background. So a chain of carbons with hydrogens attached. At certain points, there's what we call a double bond. And if the double bond is at the 6th carbon from what we call the omega end, which is the H3C molecule you can see here, so 1, 2, 3, 4, 5, 6, it makes it an omega-6. If it's at the 3rd carbon from the omega end, 1, 2, 3, it makes it an omega-3. But what is particularly interesting is that a subtle change in the position of this double bond dictates how the fatty acid behaves in the body. So omega-6 are pro-inflammatory, they've been linked with inflammation, and omega-3 are anti-inflammatory. But what really matters is not so much the actual, the absolute values of this in the blood, it's more the ratio between the two. What we need is more of the omega-3 and less of the omega-6. And in the Western diet, the ratio is in the wrong direction. These are sources of omega-3 and omega-6. Alpha-linolenic acid is a plant-based source of the omega-3. These are types of oils that you can find the omega-3. And olive oil in particular has different types of fatty acids. It's particularly rich also in omega-9, the monounsaturated fatty acids, which are highly inflammatory and antioxidant, which is what gives olive oil these incredible properties. EPA and DHA are the long chain versions of the omega-3, and they come from oily fish, as you can see here. And on the right-hand side, you can see here the sources of omega-6. Arachidonic acid is the animal-based source of the omega-6. Another important fact to share with you about the omegas is that in order for the omega-3, for example, to exert their anti-inflammatory properties in the body, they have to be converted from the short-chain fatty acids to the long-chain fatty acids. However, this conversion in humans is not very efficient. There is competition in the conversion from short to long chains for the same enzyme between the omega-6 and the omega-3. And this is what I tried to show on this slide. Keeping it in very lay terms, what this means and what I'm trying to say here is that if you rely entirely on plant-based sources for your omega-3, which then will need to be converted to the long-chain omega-3s to exert their anti-inflammatory functions, then you would need to consume a lot more higher amounts of the plant-based sources to get to the same place compared to what you would get to if you were to get the long-chain fatty acids directly from the oily fish. So this is why you will often hear dietitians say that if you're able to get your omega-3 from both plant and fish sources, then it's best to do that. And here are good sources of omega-3 fatty acids. You will see that oily fish tops the charts here. Salmon, high content of omega-3. So very, very useful to include and important to include in the diet. And of course, the plant-based sources that I mentioned earlier, including walnuts. But again, remember the point that I made about needing to consume a lot more of the plant-based sources to get the same anti-inflammatory effect compared to if you were to get your omega-3s also from oily fish. Now, this is, again, going back to the scientific evidence. This is a study that looked at the effect of using long-chain fatty acids, the EPA and DHA, more than 2.7 grams per day for a period of 3 to 4 months in patients with inflammatory arthritis, and particularly the effect on morning stiffness and the number of painful and tender joints. This was, again, a systematic literature review and meta-analysis looking at the evidence from many other existing studies, and it concluded that the intake of the long-chain fatty acids was associated with less morning stiffness and also a lower number of painful and tender joints in these patients. This is another important study in the literature of nutrition and rheumatic diseases by Proudman, published in the Annals of Rheumatic Diseases. And it looked at the supplementation with high doses of fish oil, the long-chain fatty acids again, for a period of 12 months in patients with RA. And it showed that, again, very top-line message is that patients who were consuming this high supplementation of long-chain fatty acids were more likely to fail their treatment, requiring a change in their disease-modifying drugs, the DMARDs, and they were also had a higher chance of achieving better outcomes, including remission. So take-home message 3, and just to give you the head-ups, we have about 10 to get through. Omega-3 supplementation of at least 2 grams per day may reduce inflammation and improve symptoms in inflammatory joint disease. There is enough evidence to support this kind of recommendation, and this is why it is also recommendations that's included in the French recommendations on nutrition and inflammatory arthritis. Now, salt is an important constituent of the Western diet, and salt is known to be highly inflammatory through a number of different mechanisms, including stimulating all those cells and macrophages and other sort of cells involved in the inflammatory pathways of rheumatic diseases that lead to disease and inflammation. And I have to say that the biggest issue with salt is when it's added to snack foods, breakfast cereals, and ultra-processed foods, such as, for example, crisps. That's when it becomes a particular problem. This is again a study based on the SUN cohort, well known in the literature of nutrition and rheumatic diseases. It's a study that again had a considerable number of patients included, over 18,000 individuals, and it looked at the relationship between the daily consumption of sodium and the diagnosis of RA, rheumatoid arthritis. And it showed that there was an association there with a higher intake of sodium being linked to a higher risk of developing rheumatoid arthritis. And this was an effect that was more prominent in smokers, possibly because with smoking, we know that there is already an association with developing rheumatoid arthritis. So a more potent effect with the combined effect of smoking and sodium use. And this leads me on nicely to these beautiful words of world of herbs and spices, which are a good alternative to salt. And not only they enhance the taste of food, they also improve the smell, the color of food, and many of them have also been shown to have anti-inflammatory and antioxidant properties, which is why we're increasingly seeing them on health shop displays. And I'm just going to read through different types of trials. I've chosen specifically more recent trials, again, to show you the type of evidence that is out there. So this was a study, a clinical trial on ginger. It looked at the disease activity in RA patients and the use of ginger in 70 patients with RA and active disease. And it showed that daily consumption of ginger powder was associated with better disease activity score in these patients through the expression, the altered expression of genes associated with inflammation. This is a clinical trial on cinnamon. Note the numbers of patients included 36 women with RA, randomly divided into two groups. The intervention group including patients with RA taking 2 grams of cinnamon per day. And the study showed that there was a reduced disease activity score in patients using the cinnamon, better visual analog scale, less tender and less swollen joints over the 8-week period of the trial. This is another clinical trial on sesame, which showed that sesame was associated with less inflammation in the blood, a lower number of swollen and tender joints, and a better overall disease activity score in patients with rheumatoid arthritis. Note, sample size 44 patients, follow-up 6 weeks. And this is yet another trial from only a couple of months back, looking at curcumin, which is the active ingredient of turmeric. And this trial tried to answer the question of whether curcumin could maintain remission in patients with rheumatoid arthritis while they tapered their conventional disease-modifying drugs. And to cut a long story short, what this trial showed was that curcumin actually did not impact what we call the flare-free survival. In other words, it didn't have an impact on whether patients flared or not over the 52-week period of the study in patients with RA. And this was despite curcumin achieving adequate levels in the blood. So you can see the kind of evidence that we have on these various different types of herbs and spices. So I think although there is some evidence there, we're increasingly hearing this in the news and also with different types of trials, we do need to exert caution in the way, first of all, we interpret and the results that are given to us. We do need more robust evidence and more well-conducted studies with better sample sizes, better durations. One of the problems also with this kind of studies that look into various food components, nutritional elements, and the impact on outcomes is that there is a lot of what we call unmeasured confounding. So many factors that are actually difficult to measure as part of the trial, but which could be impacting on the results seen and the associations that are seen with various food components and various outcomes studied. So we need more. Now, if Dr. Filippo was here and many other dietitians, they would give tips for salt restriction. So I wanted to share this with you, some practical tips there for you all. Dietitians will generally say, limit your salt to during cooking, as opposed to using it on top of your food. For example, limit the consumption of salty foods such as cheese, salted nuts, crisps, and processed foods. Be aware of hidden sources of sodium. I was really surprised myself to see the sodium content of some breads that I was consuming, and also the sodium content of some of the children's snacks and foods that are out there on various shop displays. And use more herbs and spices to add taste to your food, to enhance the smell of the food, the color. And remember that also this come with a potential to reduce inflammation. Salt restriction is particularly important in our patients on corticosteroids, so drugs like prednisolone, because with the use of these drugs comes the retention of sodium, so it's an added effect there. So we need to be particularly cautious if we are using this type of drugs. Now, it's not just about salt. Sugar is another important constituent of the Western diet, and sugar has been linked to inflammation. going back to the evidence, this is a study again based on the Nurses' Health Study in the US. This time 180,000 women are included in the study. And the study showed that the regular consumption of high fructose corn syrup sweetened soft drinks, which are common in the US, was associated with an increased risk of developing rheumatoid arthritis in adult women. Now, the link between sugar and rheumatic diseases and inflammation is not a very direct one. It's not the levels of sugar itself and themselves in the blood that are the actual problem. It's what the sugar actually does in the body. And I'm trying to explain this to you now. So if we consume this kind of drinks, very sugary drinks, or foods that are generally high in what we call the glycemic index, so milk chocolate or anything that's sort of ultra processed as well, what will happen in our sugar levels is that this will go very rapidly up. This rapid increase in the sugar levels in the blood will stimulate the secretion of insulin, which is released by the pancreas as a natural response to bring down the sugar levels. So once insulin is reduced, which is actually a stress hormone, the sugar levels in the blood will then rapidly drop. This rapid drop in the sugar levels will stimulate the secretion of cortisol, which is another stress hormone. And this is what essentially sugar does in our blood. It creates a very stressful environment. What we need to be consuming is food with a low glycemic index, which led to a very steady increase in the sugar levels in the blood, and not a big spike in the blood, the sugar levels, and a steady decrease thereafter. And here are examples for you of low GI foods: beans and lentils, pasta al dente. This reminds me to mention to you that the way we cook our food also matters. Generally, it is recommended that we eat our pasta al dente and not overcooked, because if you overcook the pasta, that will release the carbohydrates, it will change the starch properties, and it will turn them from low glycemic index foods to high glycemic index foods. And you can see different types of fruits as well that are examples of low GI fruits that are good to consume. On the other hand, these are examples of high GI foods. White bread, some brown breads are also high GI in their index, so they lead to these big spikes in the blood sugar levels. White potatoes in all sorts of different ways cooked that I show here, so baked, pureed, or fried, they are high in their glycemic index. Many breakfast cereals that we and our children unfortunately consume, they are high in GI. Even melon, watermelon, they lead to big spikes in the sugar levels, although they do have other good properties. These fruits, rice cakes and crackers are examples also of high GI foods. So take-home message 4 is that it's important to consider limiting salt and sugar intake and to use more herbs and spices in our daily diet. So here is a brief summary of what we should be avoiding in red here on the left-hand side, and the kind of diet we should be consuming here on the right-hand side in green. So we should be consuming a diet that's low in added sugar, high in phytonutrients, which are plant-based chemicals that have important antioxidant and anti-inflammatory properties, foods that are high in fiber, low in glycemic index, low in the bad fats, the saturated and the fats, the omega-6, for example, but high in the monounsaturated fats, high in omega-3 fatty acids, whole foods, and foods that are naturally rich in vitamins and minerals. Just going back to the evidence again, this is a study that looked at the use of an anti-inflammatory diet in patients with rheumatoid arthritis. And you can see the sort of diet that was consumed here. For breakfast, this included fiber-enriched oats, low-fat milk, omega-3 sources, low-fat fermented dairy, probiotic foods. And for main meal, you can see again omega-3 sources from fish, yogurt, rapeseed oil, honey, and spices as part of the main meal that was consumed. And this study, again, keeping it very top line, showed that there was an improvement in the disease activity of patients with rheumatoid arthritis during the intervention diet, but not during the control period. So there seemed to be an association between the disease activity score in these patients and the consumption of the anti-inflammatory diet. And back in the 1960s, and as per the so-called 7-country study, Crete, one of the Greek islands, and southern Italy were amongst the winning countries in terms of having the lowest mortality rates from cardiovascular disease. And this was found to be secondary to the adoption of what is today known as the Mediterranean diet. So here is what this much mentioned diet is all about. There is an abundance of anti-inflammatory food, minimally processed food, lots of extra virgin olive oil, which is rich in omega-9, as we said earlier, and has anti-inflammatory and antioxidant properties, pulses and legumes, as well as lots of seasonal vegetables, regular intake of yogurt and dairy and fish a couple of times a week, fresh fruit for dessert, and red meat in moderation and preference for lean meat, even a glass of red wine. So just a quick note on the red wine and the association between red wine and the antioxidant properties. Red wine contains resveratrol, which is found on the skin. It's a plant chemical that's found on the skin of the red grapes. And this is what gives red wine its anti-inflammatory and antioxidant properties. And these are food components in the Mediterranean diet that can modulate inflammation. So the long-chain omega-3 fatty acids that we mentioned earlier, the omega-9, so the monounsaturated fatty acids, phenolic compounds, which are readily absorbed through the intestine, and they confer lots of benefits to human health. They're highly antioxidant. They avert the damage from cells from what we call the oxidation, free radical oxidation reactions. So they prevent these highly inflammatory environments that can be created in the gut. And we've mentioned resveratrol earlier in the context of red wine found on the skin, as we said, of the red grapes. Now, extra virgin olive oil also deserves particular attention. We mentioned already that it is rich in omega-9, the oleic acid, polyphenols, so plant chemicals with these incredible antioxidant properties, which can lower the risk of heart disease. They lower the bad cholesterol in the blood, what we call the LDL cholesterol. They lower the total level of cholesterol in the blood, and they generally help to prevent plaque formation in the arteries. So olive oil consumption, the extra virgin olive oil consumption, has been associated with a reduction in the risk of developing autoimmune diseases, reduction in the cancer risk, improved drug absorption, and generally lower levels of inflammation. So very, very potent. Now, this is another study going back again to the evidence to again show you what is out there. This is a topic that has been increasingly gaining attention in the literature of nutrition and rheumatic diseases. And I've chosen specifically, where possible, more recent studies. So this is a study that looked again in patients with rheumatoid arthritis and the effect of the Mediterranean diet and a regular regime of exercise. So there were 4 different arms to this study. One was a combined Mediterranean diet with a regular exercise regime, versus the exercise regime or the Mediterranean diet alone, and versus control. And again, top line message here, the Mediterranean diet and exercise, both individually but also combined, when used together, had beneficial effects on overall quality of life, on physical function, but also mental health function. And of course, the combined effects were more potent in some of these outcomes. When we looked at the evidence with our team on the Mediterranean diet and fish oil supplementation and rheumatoid arthritis outcomes, again, we were able to confirm based on the evidence available that there are important benefits that this kind of diet confers us on disease manifestations, pain, arthritic pain, and physical function, but also on the comorbidities that are commonly seen with rheumatoid arthritis, including cardiovascular disease. And there seemed to be another benefit when the Mediterranean diet was combined with omega-3 supplementation. So take home message 5, we're halfway through. it seems that there is enough evidence to suggest that the Mediterranean diet or lifestyle represents a good and balanced approach to follow. And I certainly recommend it to my patients. Now, a quick note on various different other types of diet. Now, the vegan diet, this is a diet whereby there's a complete elimination of any animal products. And the evidence on vegan diets that I'm showing here comes mainly from older studies. But generally, vegan diets have been associated with reduced symptoms in patients with RA, better disease activity, reduced pain, reduced in the joints and reduced the swollen joints. Many studies, though, included a fasting period before or after the consumption of a vegan diet. So one of the problems with these studies is that it's difficult to know whether the beneficial effects that we're seeing in patients was due to the fasting or due to the vegan diet or due to the combined effect of the two. Quick note on ketogenic diets. These are diets whereby we restrict the carbohydrate intake significantly to only 5 to 10% per day and replace it with a high-fat diet. So there's a shift in the metabolism towards ketone body formation. And what this shift in ketone body formation does is that it stimulates a cascade of events that can help to reduce the secretion of pro-inflammatory molecules. We've mentioned insulin earlier as a stress hormone. Ketogenic diet would result in a reduction in insulin because of the reduction of carbohydrate intake. Increase in glucagon, which again is associated with the production of more anti-inflammatory molecules in the blood. And of course, a reduction in weight, which is why many people use ketogenic diets. Just before I give some general opinions on these types of diets, I want to mention the issue around gluten. This is a question that I keep coming across also from my patients: gluten or no gluten for rheumatic diseases. What should people do? And we've been recently invited with Dr. Filippo to write an editorial on this. It's a very important topic. It has again attracted much attention also in the press. And I think what we can conclude from the evidence that is currently available is that there is no scientific evidence to support limiting the use of gluten-based foods in rheumatic and musculoskeletal diseases unless there is confirmed celiac disease. There is another condition that I should mention. It's called gluten-sensitive enteropathy. So in the absence of celiac disease, some patients may still notice that they're sensitive to gluten. So they may have a gluten sensitivity, and sometimes these patients will report that excluding gluten makes their symptoms better. And in that case, I'd say, well, if that works better for you, then that's what you should do. But an important message to give you is that avoidance of gluten may carry additional health risks, partly also because of the processing of foods to remove gluten in those gluten-free manufactured foods. It also leads to unnecessary financial and quality of life related burden. Gluten-free foods can be very difficult, for example, to find in some countries, like the Mediterranean countries, and they can also be very costly. And this is just to give you an idea of naturally gluten-free foods and those gluten-free foods that are manufactured here on the right-hand side. Again, it's best to consume, if you have to exclude gluten from your diet, it's best to consume naturally gluten-free foods. And remember that gluten-free foods are highly processed and often lack important nutrients, minerals, fibers, vitamins, which can lead to important deficiencies. And this is the point, these are the points I'm trying to make in this slide, that the concerns around these types of diets and generally elimination diets is that they can lead to a lack of a balanced diet. The quality of the diet may vary, and generally they need to be done with great caution to ensure that patients do not become deficient, like in the case of vegan diets, in important vitamins and minerals. So I would strongly suggest that dietitian advice is obtained in this case. And this is my take-home message 6 for you. Elimination diets can result in important deficiencies, and caution is needed to ensure that patients follow balanced diets. Now, Comorbidities, we've talked about them previously. They're very, very important to remember. At least a third of patients with rheumatoid arthritis and other rheumatic and musculoskeletal diseases have at least another coexisting condition, and it is important not to ignore these conditions. We've talked about inflammation being central to the pathogenesis of the rheumatic disease itself in many cases, but also to comorbidities. And there's a very strong link that has been demonstrated through research between inflammation and the risk, for example, of heart disease or brain-related disease. So there's been a risk identified between inflammatory molecules and the development of depression, for example. Links between inflammation and bone effects, liver effects, effects on insulin resistance, and so on. So it's very, very important to not ignore comorbidities and think about them also in the context of diet. And here are some tips for you for improving cardiovascular disease risk, which is one of the commonest comorbidities in the context of inflammatory rheumatic conditions. And this very much goes around the consumption of the good types of fatty acids from fish-based sources, extra virgin olive oil consumption, oats, which can help to lower the bad cholesterol, the bad fats in the blood, use of unsalted nuts, for example, which are rich in the good types of fatty acids. Plant-based sources, I think there is a general sort of move towards consuming more plant-based diets, which come with lots and lots of benefits, and avoiding saturated and trans fats, red meat, highly processed foods, sugar, and salt. Now, very, very important for us rheumatologists and healthcare professionals working in the field of rheumatology to work together. And this leads me on to this important message that I often share with colleagues, that rheumatologists, dietitians, and other members of the multidisciplinary team should work together with patients and discuss dietary patterns and choices according to individual need. So we do need to think about sociocultural factors that come into the picture, including, for example, religious impacts on dietary choices, food as a means of social interaction, for example, especially in Mediterranean countries. And it's also important to realize that with diet that it's about personalization. Something that helps you or makes you feel worse or better may not necessarily have the same effect on another person. Now, based on data from our group, looking at the effect of body mass index or obesity, inflammation, and disease activity in two of the largest and longest rheumatoid arthritis cohorts in the United Kingdom, we found that our patients with RA in these studies together included 2,700 individuals with RA. We found that patients with rheumatoid arthritis had an increase in their body mass index and their weight over time. But we also found that obese patients with rheumatoid arthritis, compared to those with a normal or overweight BMI range, had lower chances of achieving low disease activity on remission at 5 years, but also at baseline. So this study allowed us to conclude in simple terms that the higher the body mass index, the worse the disease activity in these patients. And it made the point that as rheumatologists, we really need to think about the issue of weight, obesity, overweight in our patients with RA. And this observation that from our cohorts in the United Kingdom aligned with data from studies on bariatric surgery in patients with rheumatoid arthritis. So bariatric surgery, whereby, for example, people undergo gastric sleeve surgery to reduce their food intake and therefore aid their weight loss. And these studies have shown that in patients with rheumatoid arthritis who had undergone bariatric surgery, they had a better chance over time in achieving better disease activity states. So weight loss is a critical factor in reducing inflammation. And together with exercise, there's definitely an added benefit there. There's direct effects on the immune system, direct effects on fatty tissue, and indirect effects on the liver that help reduce the overall blood concentrations of inflammation and help to reduce these pro-inflammatory states that have been linked with disease. So take home message 8, weight loss using a safe approach, ideally including diet and exercise, can benefit people living with rheumatic and musculoskeletal diseases. Now, this is another important topic. In brief, I'd like to mention that vitamin D deficiencies can be a big problem in our patients with rheumatic diseases. I see it a lot at King's where I practice. And low vitamin D has been associated with worse outcomes in various types of inflammatory joint disease, including RA and spondyloarthritis, but also in connective tissue diseases. But it was interesting, this study from a couple of years back that showed that in patients with lupus, and lower vitamin D levels, they were more likely to develop metabolic syndrome and therefore were at higher risk of cardiovascular disease and also higher risk of insulin resistance. So very important to identify the problem of low vitamin D and replace, ideally through natural sources, but if not possible, then through supplementation. And here are some tips on how to improve and prevent risk of developing osteopenia, so bone thinning or osteoporosis. And I guess the big point to make here is that frequent consumption of seasonal fruit and vegetable is a key part here in improving bone metabolism. It's not just about calcium and vitamin D. You can see various types of sources of food that provide you with these important bone components, but it's also about other nutrients, minerals, and vitamins, magnesium, vitamin C, vitamin K, and potassium, which play a crucial role in bone metabolism. And you can see the various different types of food sources that you can get this from. So take home message 9, we're nearly there. Vitamin D supplementation should be considered in patients with deficiency, but I have to tell you that evidence on other vitamin supplementation is limited, so we cannot make robust recommendations on other types of vitamins. Now, in order to, and I'm finishing now, in order to make this topic, this incredibly big and fascinating topic of diet, inflammation, rheumatic diseases more complete, I have to mention 2 other areas. It has to be very brief because they are areas that deserve a whole session on their own. So the gut microbiome. Immune modulation, so the immune system and its functions are directly linked to our gut microbiome. And in healthy individuals, the gastrointestinal tract is colonized by a broad range of microbes, what we call collectively as a gut microbiota. There are trillions of these organisms in the gut. They include bacteria, fungi, and viruses. And about 80% of the antibodies in our body are produced in the digestive tract. And the gut microbiota, these microorganisms, are a major driver of immune cell differentiation, and they are the immune cell production, and they sit in the gut. So keeping our gut healthy is very, very important. And this is where pre and probiotics come into the picture. Prebiotics are those fibers that are not digestible by our body and thus help our gut microbiome to grow and stay healthy. And they include foods like asparagus, artichokes, bananas, beans, peas, oats, onions, leeks, and garlic. Probiotics are those live bacteria that are found in fruits and supplements. And the examples that I've given you here include kefir, which is sour milk, sauerkraut, which is sour cabbage, and tempeh. And generally, dietitians recommend that we consume a few portions of both pre and probiotics on a daily basis to keep our gut healthy. And secondly, the other big topic that deserves at least a brief mention is that of the circadian rhythm and its role in inflammation. So the circadian rhythm, in other words, the circadian or biological clock in the body is very, very important. It sits in the hypothalamus in our brain. And in all individuals, the circadian clock drives daily rhythms as part of normal physiology. The circadian rhythm will control the sleep-wake cycle. And there is as an example, there's an important crosstalk between our biological circadian clock and the immune system. In very simple terms, the one message that I'd like to give you in relation to this is that the times that we consume our food And the times that we sleep, for example, are very important and ideally should be regular on a daily basis. And this becomes particularly relevant in shift workers who sleep and eat at very deranged times and very non-consistent times. And this can be a problem when it comes to inflammation. So take home message 10, last but definitely not least, it is important to keep a healthy gut, consume appropriate food at regular times, and maintain a good sleep hygiene. And these are all the take home messages that I have taken you through in the past 45 minutes or so. I won't repeat this, but I hope I have been able to give you at least some insight into this important topic and to have inspired you to consider some of these recommendations. And as a final note for me, when I was browsing the beautiful Arthritis Ireland web pages, my attention was captured by the vision of Arthritis Ireland that states that a better world for people living with arthritis today and a world without arthritis tomorrow. And I share this vision, and I believe that we can achieve a better world for these people and a tomorrow without arthritis. And diet may be a small but important step towards achieving this. Thank you for listening.
Thank you very much, Elena. That was comprehensive and really fascinating. It's no matter what we talk about at any event or anything like that, diet and nutrition is always brought up, and you mentioned that. So it's been something that we've been looking forward to, I'm sure. I'm going to zip through some questions, and hopefully we can get through all the ones that have come in, because we are pressed for time. I'll throw them at you, and hopefully you'll be able to give me some answers as we go through. The first that I'm going to go to is it's just someone who's basically followed all the rules that you've gone through there and the 10 guidelines and done eating all the relevant vitamins, eating loads of veg, no smoking, little or no alcohol, but still have a lot of pain and inflammation. And I suppose is there a point of that can still happen for people despite all the best efforts?
I mean, it's a very good question, and I mean, I have to say it's incredible if there is someone who can do all this, and, who can really achieve this, and well done to those people who can really do that. I struggle, I have to say myself, with keeping up with some of this, but it is ultimately all about personalization. Every individual is different. Their needs are different. Their responses are different, both to pharmacological and non-pharmacological interventions. And that can happen. It can happen that people try everything, but they still have residual symptoms. They're still not able to get on top of their disease. And that's where we need to have a more individualistic approach, really carefully think about these individuals, think about potentially other factors that may come into this. Sleep is part of that. If they've also been able to achieve good sleep and they're still struggling, then we need to think of other areas that they might be an issue. They may have disease, a phenotype of disease that is just resistant to many things. And this is why nutrition is not everything. One of the messages that I want to give is that nutrition is hugely important. We really are, to a large extent, what we eat, but it's not everything. And it should by no means replace pharmacological therapy. There is no evidence currently to suggest that nutrition can and should replace pharmacological treatment, for example.
Excellent.
I hope
Thank you for
that.
Yeah, I think so. I think it'll get to that. Two related to cooking. One is, are fish oil supplements as beneficial as taking cooked fish? And then secondly, in relation to olive oil, is that effective, or is it good to use for cooking, or is it more effective cold?
Yeah, a very good point. So I think most fish would be eaten cooked, at least in Mediterranean countries, and we know that that comes with those benefits that I mentioned as part of the Mediterranean diet. And in terms of the olive oil question, the oils have a specific sort of temperature threshold. If you overcook oil, so if you use olive oil in your frying and you overcook it, then we can destroy the properties. So it's better to use it raw, for example. And that applies to many oils. They change their properties.
Okay. And then two relating to caffeine intake. So are there any recommendations relating to caffeine intake? And then there was another one that I saw there in relation to caffeine. It
Was
may
it
have.
the one about evidence that caffeine causes greater inflammation, or that
Yes. Yes.
calcium be leached from the bones? I saw that one.
Yeah. Yeah. They were both related to that, Elena.
It's a very controversial area. And
Okay.
I have seen mixed studies, mixed reports from studies that caffeine confers benefits, but I've seen studies that show that it can exacerbate symptoms. So I think before we answer that question robustly, we need good evidence and good studies to help us answer that. There is evidence also on caffeine, coffee, and Alzheimer's use. So you really need to think of the picture more holistically, not just a rheumatic disease, but also comorbidities. But we need more evidence.
Okay.
And just to add to that,
Yes.
Peter, sorry, an important message is everything in moderation. I don't want people to leave this webinar feeling depressed. I cannot have crisps. I cannot have, sugar. It's all about moderation and having more of the good stuff and less of the less good stuff.
Yeah, there's just one here about herbs and spices. So it was noticed that no real benefit from turmeric was found in the study that you discussed. Have other studies found any benefit, or is that again a personal decision or impact?
The particular study I shared is a very recent one, which is why I included it, and it looked specifically at flare risk when patients with rheumatoid arthritis were withdrawing their disease-modifying anti-rheumatic drugs. So in that outcome, turmeric, curcumin was not found to have an effect, but it has been found to have anti-inflammatory and antioxidant effects in other studies. So the evidence is accumulating.
Okay, and this will have to be our final question, but I will refer to the others in my wrap up in a moment. But what do you think about companies that discuss personalized diets that claim to, amongst other things, reduce inflammation? Is there enough evidence, or is it at a robust enough stage to be a convincing approach at the moment?
I would really explore and do my research very carefully before engaging with a lot of these and supplements that are out there. A lot of it, unfortunately, is about money making, and one has to be very, very cautious. I really love the idea of personalization. It should be all about that because every individual is different. This is where programs like the Zoe study come in, where there is a more personalized approach to what works well or bad for patients. So in those kind of programs, which are heavily studied, there's incredible scientists behind them. Then yes, but caution with more industry related sort of a money making kind of businesses. I think we have to exert caution there.
Okay, well, there are some questions left there, but I will say that for those that have asked about specific slides or specific information, the recording of the webinar will be up on our social media and will be available so people can see the information that Elena has shared previously, and you will be able to look back on it and be able to go into it in much more detail when you see that. It just leaves me to draw our webinar to a close. To remind you, we have two more left in our series. Next week we'll be discussing pain and mental health. And then we conclude with living a life with pain with our psychotherapist Laura Cahill. So that will conclude our series on the 9th of November. I do want to let you all know about our pilot program, Living Well with Pain, an evidence-based online program, and an additional support for everyone living with pain associated with arthritis. To book your place, go to arthritisireland.ie. It's 1 day a week for 6 weeks and a 2.5-hour session. And there are different days and times available to suit as many people as possible. So please do have a look at that. We also have our membership, e-zine and blogs. You can get our Mindful Monday blogs as well to get tips and information. Our Inflammation Nation podcast series, our website has all our information and booklets. And like I mentioned, the YouTube channel for the videos with experts and clinicians, but also the recordings of this webinar series. And then finally, it just leaves me to thank Elena Nikiphorou for a fantastic and really enlightening session this evening, and to also thank Fresenius Kabi for their support of this webinar series. Thank you all for attending. Have a great week, and we'll see you next Thursday at 7 p.m. Take care. Thank you.